Okay, we're here with Lori, our volunteer. We're going to do a fake knee injection. We'll do everything except for the actual needle through the skin. So for a knee injection, what I like to do is have the patient sitting vertical so the knee is in a 90-degree position and the gravity of the leg is helping pull the tibia slightly away from the femur. And what we're looking at here is the surface anatomy. Includes the distal pole of the patella, which you can see nicely right there. The distal pole of the patella is a good starting point. And then what we look for is the soft spot directly lateral to that. So the patellar tendon, I can feel ends right there by pushing in at that location. So the patella is here, the patellar tendon ends there, so I'm going to go about 1 centimeter over from that, and that's the soft spot. That allows me to find the spot that'll shoot directly into the knee joint. So then we do a little skin prep, and I'm using an alcohol swab to just wash around the skin. And this will be a simulated injection. I have a 25 gauge needle, which is what I typically would use for a knee joint injection. I would normally put 1 cc of the steroid in, and then I fill the rest of this syringe to get up to about 3.5 cc's of total volume. In this case, we're not actually going to be injecting. So after the prep, I'll spray on the skin to anesthetize the skin, and I'll generally do it a little bit more than that, but in this demo I won't do it till it turns white, but I generally wait for it to turn white. And while it's white, I'll then put the needle through the skin before I do anything else in order to get the actual painful part of the procedure over. Once the needle's in the skin, then we're going to go in probably about 2 centimeters. And I'm aiming at about a 45-degree angle to get it behind the patellar tendon, because the patellar tendon's right here. And I'm trying not to hit the distal femur, of course. So I'm aiming towards the middle of the joint, about like that. And in this case, I would certainly obviously remove the cap, insert the needle, inject very, very slowly. The slower you put the medicine in, the less it tends to hurt. If I encounter any resistance on the needle through the plunging portion of the procedure, if there's resistance, I'll pull back and slightly re-angle it to get it away from either a bone or soft tissue structure that I may be hitting, such as the ACL or the fat pad inside the knee or the distal femoral cartilage. Okay, and then after that, of course, the Band-Aid goes on and she's all set to go.